Hello, everyone. Welcome to day 2 of the CCIH 2021 virtual conference. I'm Mona Bormet, Program Director at CCIH. We are so glad you could join us for the conference. I don't know if anyone else was dancing a little bit in their seat to the music. Maybe that was just me. But we look forward to being able to meet together in person again soon. But for now, we're really grateful to have this technology to bring us together. And so right now on the slides, you will see the sessions of the conference, but also there will be a slide with instructions in French and Spanish to help you join the language interpretation channels. So we hope that's clear, and we'll be reminding people of how to do that throughout the day. Just so you all know, we're going to hold all questions until the end of the program today, which will be approximately 9:40 US Eastern Time. We'll collect all questions until then. So please use the chat box to introduce yourself and also to ask questions. We have staff monitoring that. And right now, I'd love to turn it over to our moderator for today's session, Dr. Mwai Makoka. He is the Program Executive for Health and Healing at the World Council of Churches based in Geneva, Switzerland. Dr. Makoka also serves on the boards of the African Christian Health Association's platform, the Ecumenical Pharmaceutical Network, and CCIH. He qualified as a Doctor of Medicine in Malawi in 2002 and received further training in public health microbiology and infectious diseases in the US. And besides clinical practice, Dr. Makoka previously worked in the National HIV Program and in academia, and he was previously the Executive Director of the Christian Health Association of Malawi. We're so happy to have Mwai with us, and I will turn it over to him. Welcome, everyone.
Thank you, Mona, for opening up our session, and welcome everyone. We are glad you have been able to join us today. I'm Mwai Makoka. If you're new to CCIH, just a bit of a background, we are an international network with nearly 120 organizations, Christian organizations, and 15 non-faith partners, and a few hundred individual members, most of whom are based in the US. CCIH's mission is to promote health and wholeness from a Christian perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. Now, if you're not a CCIH member yet, I would like to encourage you to consider becoming one, either as an organizational member or an individual. This session is being recorded, and we'll post it on the CCIH YouTube channel in a conference playlist. And you'll find links to the recordings on the CCIH website at ccih.org under events, so that we can visit and watch this, also share with friends and others who may not be able to join us today. Now, we're grateful for our sponsors who have helped make this conference possible. Today, we acknowledge Kiwa International, who have sponsored our day today. The mission of Kiwa International is healing the sick and proclaiming the kingdom of God. Kiwa International operates charitable hospitals and programs in 14 countries worldwide, where patients experience the life-changing message of God's love for them. Kiwa specializes in providing surgery to children to treat conditions such as clubfoot and other disabilities, untreated burns and hydrocephalus. We thank them for their support. Our theme today is leadership and governance. They are a bit tricky to tell apart, And I think there's another word around there, management. So, but we'll zero in leadership and governance. In my early teenage, I used to attend boot camp. There was a Christian organization, an American organization called Teen Missions. I think they are based in, used to be out of Florida. Now they were running summer camps for teenagers in some parts of Africa. They used to do that in Malawi. And they would put it in small teams, maybe 15, 16 kids in one team, and each team had a leader. And part of the learning was discipline. And so, for example, if you are late for your dinner, then you would get a small punishment. Bible studies and meetings and all that, you have not cleaned up your tent, then you get a small punishment. What was more frustrating was that if it's actually the team leader that has lapsed, then the whole team would be punished. So if the team leader is late and all of you are there, then the whole team is punished. And we used to get so frustrated with that. And it took me time to understand why they were trying to teach us in terms of how prime leadership is. So today we're looking at leadership and governance, and I'll leave that as a reflection on how the primacy and how important leadership is. Now I will welcome Doug Fountain, CCIH Executive Director, who is going to introduce our first speaker today. Welcome, Doug.
Thank you, Mwai. Really appreciate the opportunity to speak today and share something that I was able to do. Thank you for that opening. I just had to reflect. You know, I love that you shared a story from that, and frankly, that was making me think back to my early childhood formation as well. And I won't tell the stories about that, but let's talk about in the interview that I did recently with the Most Reverend Dr. Stephen Samuel Kaziimba. He's the Archbishop of the Church of Uganda. I wanted to understand the mind and heart of leaders of our global church with whom we share responsibility in Christian health work. Archbishop Kaziimba oversees the work and ministry of 37 dioceses that make up the 13 million member Church of Uganda. The church also operates 256 health centers, 13 hospitals, over 5,300 primary and secondary schools, 50 vocational programs, and 6 full universities nationwide. He serves as the chancellor of one of those, Uganda Christian University, which is a place where I worked for a number of years and I still volunteer. Archbishop Kaziimba has a Master's of Divinity and a Doctor of Ministry that he received from Western Theological Seminary in the US. He also chaired the Committee for HIV and Public Health for the Interreligious Council of Uganda. He recently authored a book on empowering the laity, which alone says something about his approach in leadership. Archbishop Kaziimba came into his position just as the COVID pandemic took root globally, making his perspective especially timely for us. What we will show are excerpts of an interview that I did recently with him, and we'll make the longer version available for conference registrants after this conference. So thank you. With that, let's take a look at the video. Thank you.
Very much, Brother Doug Fountain. I want to appreciate you for thinking about me to be part of this conference. I am very, very grateful. And for the work you are doing to ensure that people live. And as a Church of Uganda, definitely, when I was invited, I felt this is very, very important, because our theme for this year It's from John chapter 10, verse 10b. He came that we should have life and have it in its fullness. And so I very love what you are doing, and I'm sure God is calling us to partner together with you for the great ministry of having life in its fullness.
How has the global crisis affected your leadership style? What have you had to emphasize differently because of COVID?
Oh, thank you so much, my brother Doug. You are right, you are right. I was installed as an Archbishop on March 1st, 2020, and as a Bishop of Kampala on March 8th, 2020. And in just a few days after that, there was a lockdown. It affected my ministry because I had written a church with many goals. As you know, you set goals. I want to do this, I want to do this. All that was affected because I had no people to interact with. I am a new person in the office from a rural area, from the village to the city. You don't have the people, you don't have friends to, as per se, because I had friends in Mitiana, and now I am a new person here. Of course, you have people you know, like Dr. Alison, like in the office, but the people, even in the office, secretariat, they don't know me. Some others are not so sure whether they will keep their positions, whether the new man is going to ensure they are posted or they are removed from their positions. All those things, in the midst of that, then you cannot move on very well. So I had a program. I had to, Uganda, visiting the entire country. I had this program of development, evangelism, women ministry, children ministry, but all of a sudden, the church buildings were closed. No worship, whereby we are interacting with the people. So that was a crisis, whereby I had to be in my living room, which became the cathedral. I had no interaction with the bishops. I had no interaction even with my own clergy in the Diocese of Kampala. Up to now, it's now a year, I haven't known the clergy of the diocese, which I am responsible. I haven't known the people. I haven't visited the churches. So it affected our ministry of evangelism because of the interaction. Of course, there was a way we had to use radios, but I know when you are ministering to the congregation, virtual congregation, there's a way you miss the interaction, to know the people, to see them. All the income was affected because there was no giving in the churches, no offertories. It's not like yourselves there where you have a lot of online giving. In our church here in Uganda, we didn't have many churches that could have online giving. Just a few churches in Kampala after the crisis. But all the churches in the entire province, many suffered because of no giving. Even the office here, the secretariat of the Church of Uganda, many people lost their jobs. Others were suspended. And you see that how it affects you, because some people didn't even think about the crisis. They just concluded a new man in the office has come and chased us away from our offices, and now we don't have income. We don't know how to feed our families. We don't know how to take care of ourselves. So it was a crisis which also affected the relationship, my relationship with the people, my relationship with the congregations, because there were others who were saying, we don't see him. So definitely it affected us in the area of reaching out the people, also the area of income, the area of, it created a number of things like domestic violence in our congregations, rape cases, and also when the children were to stay with their parents at home, schools were closed, and that one affected the school ministries, because our churches here and schools, they are open because most of the schools were founded by the Church of Uganda. But now, up to now, I haven't visited even one school because the schools are still closed. They have started opening for just few candidate classes to do exams, but the church hasn't gone back to the schools to preach, to visit. So you can see how that has affected our ministry, definitely. But we thank God, when one window is closed, there is a ventilation opened somewhere. When the door is closed, there is a way God opens something always to minister to God's people.
Your Grace, in the difficulty with COVID and all of the measures that were necessary during the lockdown, the people were not able to come to church. People have been told that they have to wear masks. People are being told to do these things, all to protect their health. And you, as a leader in the church, are upholding those things. That decisive leadership is difficult. And I'm thinking about sometimes the challenge is people complain about decisive leadership, or maybe it's uncomfortable. But what are the risks and rewards of decisive leadership? And at what point does decisive leadership become too authoritarian?
Thank you very much. Actually, this has been a very challenging time for my ministry ever since I joined the ministry in 1985 as a lay reader. This has been a challenging time for me, whereby you are supposed to make decisions, and yet you are not with, you are not with the people, you are not with the other leaders to make decisions. You must use technology, but we are so grateful that this time it opened up other avenues, like using the televisions, using the live streaming, using the radios, which is not the way it was. Now we have come to appreciate technology and the new tools very much at this time. Actually, even right now as I speak, we are thinking about having our own television when God blesses us. But some of the risks that we had to face by making decisions at this time, because we had to meet the president of Uganda before the lockdown was implemented. The president had to called all religious leaders in State House, and he shared with us that there is a problem of COVID, and they are going to lock down the churches, they are going to lock down the mosques, everything has to be done. And, you know, we are saying, no, this man is not spiritual. He's not really saved. How can you close the churches? You know, there was a kind of arguments, but eventually we agreed. And we respected the president for inviting us to consult us before locking down the church buildings. But this one came with some risks. This is when we had now domestic violence in homes. Of course, there was some domestic violence, but maybe it was not known to this level.
It must be very difficult to know that you have to make these tough decisions. Like you say, those are the risks that come, and you're even experiencing and continuing to learn them. The challenges in families, the gender-based violence, the food insecurity that's coming about. What are the implications now for servant leadership? So if we have to have strong decision-making to protect people's health, even with all of these problems that will come up and all of these risks, if you have to have strong leadership, how do you then exhibit servant leadership at the same time?
Actually, when I was doing my master's in theology in Western Seminary in Harland, Michigan, I concentrated mostly on leadership, and it was servant leadership. And this is the time I have found it very difficult to implement that. Because there are decisions to be made. And I discovered that this time there are two things that I needed to give attention. It is two T's: tough and tender. You have to be tough, even from your own house, whereby people have to put on masks all the time. People are not allowed to walk outside their houses. There are some strong rules on curfew, whereby by 7, 8, people are supposed to be in their houses. You know, you must be tough, but at the same time, we have to be tender. So balancing the two has not been easy. It is something which calls for humility. It is something which calls for a kind of dialogue and discussions. It calls for flexibility, and this is what we have also encouraged a lot, even amongst families. Flexibility is needed. Collaboration, coordination, communication, cooperation, connection. It calls for Christ to be on top of everything. And I like the communication, cooperation, collaboration, coordination. It calls for connection. It calls for Christ to help, because sometimes you can go to excesses, but it's Christ who has helped us to avoid extremes, so that we can control.
Thank you so much, Your Grace. That was powerful, and I have been blessed and lifted and encouraged. I know many people who are watching this are also going to be blessed, lifted, and encouraged. There are so many messages and so many lessons that you've shared. Today, we were delighted to speak with the Most Reverend Dr. Stephen Kaziimba, who is the Archbishop of the Church of Uganda. Thank you for being with us, sir. We really appreciate it.
Thank you very much, Doug, for moderating and giving us a very insightful discussion with the Archbishop. Now we move on to the next section, which is a short section between Peter Yeboah and Agnes Moses. Peter Yeboah is the Executive Director of the Christian Health Association of Ghana, CHAG. And CHAG is a large not-for-profit and non-state provider of health services in Ghana. Peter is also chairman of the Africa Christian Health Associations Platform, or ACHAP, which is a network organization representing over 41 Christian health associations and health network organizations throughout sub-Saharan Africa. Peter holds a joint Master of Science in Health Policy, Planning and Financing from London School of Economics and the London School of Hygiene and Tropical Medicine, and also Masters in Public Health from the Royal Tropical Institute, Amsterdam, the Netherlands. Peter is joined in this discussion with Dr. Agnes Moses, who is the Executive Director of Partners in Hope in Malawi. In addition to strategic leadership for the organization and PEPFAR and USAID funded programs, she provides direct clinical leadership and patient care at BIH Medical Center in Malawi. She has broad experience in public health, clinical practice, clinical research, and healthcare leadership. She studied in Malawi, South Africa, and Australia, and has participated in several national health technical working groups, and is an independent reviewer of the Malawi Medical Journal. She is a certified trainer and educator for both undergraduate and postgraduate medical students. Welcome, both of you, Peter and Agnes. I'm privileged because both of these are my friends, so you will forgive me if I'm too chatty. But we'll start with you, Agnes, to share with us the leadership skills which you think have helped you as a leader. What motivates you? Sometimes leadership can be challenging, as the Archbishop has aptly shared. So what motivates you to lead? Okay, you have to unmute now. Thank you.
Thank you, Mwai, and welcome everyone again to this session. I am indeed Agnes Moses. I'm Malawian, as you can see by birth and otherwise. In terms of leadership, I joined Partners in Hope, which is an NGO or faith-based NGO in Malawi. We have a hospital that has got both the paying side and non-fee paying side, but we also implement USAID grant-aided programs. So for me, I joined this organization in end of 2017, taking over from my predecessors, who were both male, I must say, Christians. So in terms of, because I don't want to waste time, what leadership skills have helped me in seeing my organization get to the point where it is now? as a start, I'm a Christian and my full dependence is on God. But apart from that, I think I'll echo what the Archbishop said. In this particular leadership position, because the organization I took over was quite dichotomous in a lot of policies, I had to exercise decisiveness in whatever I needed to do. So decisiveness is one of those qualities that I think helped me, one of those skills that helped me get through to where we are now. I said decisive, as I said, the organization was a bit more dichotomous than I thought. So in decision making, if you had to make new changes, I had to be decisive. I'll try to be brief. The second skill that I think was helpful is in leadership, people always say lead from the front. And that really makes sense. In Christian circles, we equate it to servant leadership, because people must see what you're doing and you must be in the forefront. That means also taking risks for any untoward effects or impact that may come through. So servant leadership or leading from the front, I think, is one of those qualities that helped me. And the third one, I'll just mention the third one, is promoting unity. Initially, I think as a start with your own leadership team and other managers, before you go to the list of your staff members, I have seen that work, because if there's division within your own leadership, it's very, very difficult to achieve unity within an organization. So those three qualities, without taking up much of your time, I would say they've helped me. I will just recap: decisiveness, servant leadership, and promoting unity within the top leadership. Thank you.
Thank you. Thank you very much. Peter.
Yes, many thanks, Mwai, and all the wonderful participants, friends, the virtual platform. Warm greetings from the Christian Health Association of Ghana, ACHAP, which is an active partner with CCIH. Yes, with respect to the leadership skills that are required to fulfill the functions of an executive director, I would put it this way. First, the executive director of a Christian Health Association has the overall responsibility for leading the development and execution of long-term strategies, which is aimed at promoting the growth, development, and sustainability of a Christian Health Association of Ghana. In effect, being the chief executive officer, a ED is responsible for the overall success of the CHA, including the vision, mission, direction, and overall strategy. So with this, there are certain tasks that I'll have to highlight before I come to the leadership skills. One key task is promoting always, or demonstrating the power and benefits of having this partnership amongst independent Christian denominations. That is the essence of unity. So the ED is supposed to promote unity amongst Christian denominations. The second key task is maintaining that conscious awareness of our internal and external environment. By internal environment, I mean being aware of the needs, challenges, and interests of constituent member institutions of a Christian Health Association, which is always about promoting quality, equitable service delivery. And then also being aware of the external environment that present threats and opportunities that affect, the growth of a CHA. Which means that as a ED, you must always have to come out with innovative programs at the community level that has national impact. And then, of course, maintaining presence at the policy table, be it the Ministry of Health, government, or development partners. And then finally, one key function is also to serve as a primary representative in terms of being the community and public relations for a CHA. It means that you must always have to exemplify a model of an acceptable conduct and actions that promote the reputation and leverage of a CHA. And of course, setting the standards, values, and ethics. And then fundraising is extremely important resource mobilization, especially in an era like COVID, public health emergencies, you're supposed to raise fundraise for this. So the combination of all these tasks means that 3 key leadership skills are required. First, professional skills, meaning that you should have that technical competence to provide strategy, to lead, organize, and mobilize the resources that are there. And that has been very helpful to me in terms of learning new skills always to be part of leadership. The second key skill is partnership. That has helped me. You must be nuanced in the art and science of partnership building and maintenance, which means that learning the science of advocacy, lobbying, and negotiation is very vital if you are to harness the internal and external competencies or synergies that are required. And then finally, one key skill that has helped me is having the needed personal judgment and attitude formed and informed by Christian ethos, so that at any point in time, you'll be able to have that executive presence, that calming ambience and inspirational, interaction with your constituents. I think that having these 3 skills are very important in fulfilling the key functions of an executive director. Probably I'll end there and follow up with more questions. Thank you so much.
Thank you very much. As you are aware, we are racing against time. So, but your first opening has been very good, both of you. And I think building on that, we will go a little bit faster on the remaining areas that we have to cover. Back to you, Dr. Agnes. You are leading Partners in Hope, a Christian hospital. What challenges have you faced, and how have you navigated or addressed them?
Thank you very much, Dr. Makoka Mwai. Indeed, every organization or every leader will meet challenges, no matter how strong they are. For me personally at PIH, some of it I've alluded to. When Partners in Hope is an NGO, and it has 2 units, I would say. One unit that implements USAID funded grants, and the other unit that is into clinical care. So the biggest challenge I faced was to harmonize these 2 units, to work together as one organization. Because of these, the 2 units have different policies, different financial years, different salary grades, different, you name it, everything, except that people were sharing the same name. So as a leader, I needed to have a strategy of consolidating the organization so that it should work as one organization. And this theme of today of unity in governance perfectly fits what I came through. So for us, we are not yet there, but we've made progress. For us to do that, we had to inform or advocate for unity within the people or the staff that are working at Partners in Hope, starting with the leadership, starting with the board, then the executive leadership team, then the senior management team, then it trickled down to the other members of staff. We had to deliberately restructure our policies to harmonize them, become one policy, and promote the unity in Christianity that we profess to have. So in this one, we really needed to walk the talk. I think as a leader, or with my fellow leaders, we needed to have the competence of learn and every other skill that we needed to buy in to advocate for this unity that we wanted. And within that, we also had to deliberately put it in our strategic plan as one of our goals for an organization. And as I can say, so far, we've made some progress to the glory of God, but we pray and hope that as we progress, we'll come to the actual goal that we want, that the organization will function as one. So that's one of the biggest challenges I can highlight. The others, I think, not as,
Okay, thank you. I would think that you are saying the navigation, the agreements, the unity had also to be translated into the documents.
Practice, yes.
So that the structures and the systems are speaking to the things that you have agreed upon. So,
exactly.
yeah, so that's, I think, is very critical. Back to you, Peter. I think this question, you pretty much already answered it, but I'll ask you just to, in a minute, to sort of reflect mostly on your role leading two Christian networks, okay? CHAG, which is a local network, and ACHAP, which is a regional network, and on the area of unity in diversity in Christian networks. We're united, but not unified. So just zero in on the issue, maybe just to crystallize on this specific area of unity in diversity, diverse network, diverse denominational background, and how do you navigate, and what sort of nuggets can you share with others?
Yes, many thanks. I think this has been the pressing challenges. The unity in diversity provides strengths, opportunities for us to work together. And yet, paradoxically, it is also one of the flashpoints that leadership will always have to be aware and promote. I think that the different denominational groupings with their interests and orientations would have to be harnessed. They are seen as synergies. And four key ways of harnessing these synergies with leadership, promoting unity in diversity. One is always enhancing value addition. What value add? As the leadership, we always have to assure the constituents that indeed there's a value in coming together. And one of the ways and means of also having programs, projects, and setting collaboratives that would have that collective and individual benefits, very important. And then secondly, in terms of governance, managing network organizations at the country level and continental level, consensus building and collaboration is very important. There's always the need to avoid voting by majority and always building consensus so that we'll be able to have the buy-in, the support and visibility of key actors, in that our independence and autonomy itself means that an individual can implement something different apart from what has been decided. So consensus is very important. And then also aware of potential conflicts, mediation and conflict resolution as an important skill is very necessary when you're leading network organization. How do you scan and scope, identify potential conflicts, latent ones, competition, and then mediate and then resolve conflicts amongst partners? I think this is very important. And then finally, building trust, credibility, connection, and networking is very important. There's always the need for leadership to build trust, build relationship, see areas of potential collaboration, areas that brings us together, and then, of course, try to manage or mitigate potential events of conflict. So these four areas, enhancing value addition, consensus building, mediation, conflict resolution, building trust, credibility, confidence, and networking, is an important pathway of enhancing unity in diversity, which is a strength and also a challenge. Thank you so much.
Thank you very much. Value addition. What's in it for me? What are we doing in there? But also as the leader, you need also to, as you're saying, to show them what is it that they have to give. You may not benefit, but others will benefit from your presence and your engagement. We are running out of time. So I will ask you, Peter, to be framing some closing thoughts. And I will ask Dr. Agnes to share with us very briefly, because you have worked in government, you have worked in a university research institution, and now you are heading a Christian institution. So do you think there is any difference? What makes PIH and leadership at a Christian institution different from a non-Christian institution or a government? Is there any difference? Do you need any different skill sets? What is it? Is it the same? Is it different? Briefly, we have very few minutes. So maybe in 1.5 minutes, and then I'll come to you, Peter, to give closing thoughts. Dr. Agnes, you are on mute, I think.
Yeah, thank you, Dr. Mwai. Yes, in terms of the difference between a Christian organization, leadership in a Christian organization as compared to non-Christian, I would put it broadly as non-Christian organization or public institution. According to my experience, is that in the Christian organization like PIH, the expectations are that you will walk the talk. Whether the rest of your members walk the talk or not, but they expect very high standards for you. For example, at Partners in Hope, our motto, we say Christ's words in Christ's love in words and deeds. So the emphasis here is on deeds. They expect you to be exemplary and to be a proper guidance, exemplary in your work, both technical competency and also in your spiritual leadership, like at my organization. If that is not demonstrated, I think in most cases, then there's nothing to follow. The other point I can point at is they expect even you to be the first one. I think Peter mentioned it somewhere, that when you talk of sacrifice, they expect that to come firstly from you. So in short, in the Christian leadership, servant leadership is emphasized. On top of that, your words must be manifested in your deeds as well. It's not just talk. Thank you.
That is a very good synthesis. And I'm sure I'll go back here. If I won't need to make any presentation, I just go this and take the notes. and then I will shine, because I think you guys have been very, very clear and concise. So now, Peter, finally, what are your final thoughts? What skills do you need or would be helpful? Now we just want to be a little bit forward-looking. What do you think needs to be, our main message or theme, especially for others that are coming up? You have been in leadership positions. There are others who are emerging, the young people. What do you think are the skills that they will need to lead these organizations into the future?
Many thanks.
Just a minute.
Yes, very important question. Let me preface it by saying that it took me 20 years of professional life in order to become an executive director of a Christian Health Association. Now, what I'm saying is that we need a new cadre of generation that will recognize Christian leadership as both a vocation and a profession. We need leadership as a vocation inspired by Ecclesiastes chapter 9, verse 10, that has inspired me, that whatever thy hand find to do, do it with all thy might. Very important. So that compassionate leadership would be enhanced. And this will be possible through mentorship, shadowing, accepting assignment on pro bono basis, and understanding that Christian life is both a vocation and a profession. A profession will ensure that you ensure regulatory compliance, technical competencies. So the interface of a vocation and that professional life is needed to build, a type of leadership that will sustain and then promote Jesus Christ healing ministry, especially amongst our new generation that are coming up. We need to provide that template and a model of selfless devotion. A vocation is inspired by Christian leadership and professional services. In this, we'll be able to become champions, advocates, and stewards of Jesus Christ's healing ministry and being the salt and light of the healing ministry. Thank you.
Thank you very much. My apologies to you all, because the final closing thoughts, we were also going to have Dr. Agnes Moses to also give her thoughts, but we are, our time is up now. We inherited a 1-minute bonus at the beginning, and we have not been able to donate 1 minute to the next session. So the best we can do is just finish on time. But I thank you very much. I think it has been a very enjoyable panel. And now we move to the next session. Thank you very much, Peter. Thank you very much, Agnes.
Nice. And thank you too for wonderful moderation. Blessings.
Thank you. Our next speaker is Dr. Koki Agawo, and she will focus on helping leaders inspire and guide health in technical leadership through partnerships, especially during a pandemic. Dr. Agawo is Project Director of USAID's Momentum Country and Global Leadership. She is an internationally recognized expert in safe motherhood, reproductive health, and family planning policies and programs, as well as promoting policy dialogue and advocacy for policy reform. She has more than 25 years of service delivery experience in reproductive health, family planning, maternal health, and for over 2 decades, she has led, managed, and implemented large-scale USAID-funded global health projects. Dr. Agawo is also the Vice President of DC Operations for JPIGO. Over to you. You have 15 minutes to share with us, helping leaders inspire and guide health in technical leadership. Over to you, Koki.
Thank you so much, Mwai. It's been a wonderful session listening to the previous speakers, and I think part of my presentation was covered so nicely by the session that you just had with Peter and Agnes. But I really thank CCIH for the opportunity to speak with everyone today. I'm really excited about the topic on partnership. If you can go to the next slide. And especially in the heightened need to address partnership amid a pandemic that the world is experiencing today. Next slide, please. I'll talk a little bit about the program that I work on, Momentum Country and Global Leadership. As Mwai said, this is funded by USAID, and we have several partners that contribute to this program. And we focus on developing a technical and capacity development approach to work on global initiatives and provide this support to country partners to apply evidence and best practices to accelerate progress towards sustainable improvements in the health of women and children. And we focus on making it an emphasis on partnership, mentoring, mutual accountability, co-investment of resources, and bring the program and technical rigor and adaptive management to accelerate the delivery of high quality evidence-based interventions to scale. So I wanted to share the snapshot of our country that we work in right now. You can see that we have the countries listed on the x-axis, and then all the different technical areas that we support. And recognizing that all of these technical areas we could not support if it was not for the partners that we have on our team that provide the expertise on these different technical areas. And the challenge, not only the technical areas, but also the cross-cutting areas like community health, water and sanitation, bringing in private sector, faith-based partnerships. So we all try to work together to envision a common result for the project that we can deliver on. Next slide. So our partnership approach is very much along the lines of what Peter had mentioned and what my home organization, JPIGO's approach is. So JPIGO partners with local communities and health systems at the national, subnational levels to build equitable and accessible health systems and services. And the idea is to bring better access to care, better provision of care, and better experience of care. And there are many opportunities we find for partnership and collaboration between public, faith, and private sectors at all levels, the national, subnational, to address the most critical challenges. And we know that we cannot address those challenges without the partnership. Next slide, please. So if we go to the next slide, please. The role of the faith communities in health service delivery, we know that in many settings, the faith-based facilities provide more services to communities than the public or the private sector. Faith-based organizations have a very long tradition of promoting family planning and other services. They are trusted messengers with deep roots in the community, and they play a very important role, and sometimes a really essential role in providing the contraceptive and other services, raising awareness and advocating for family planning. They can also mobilize community to change cultural norms and beliefs. They are trusted community leaders, and then they can address sensitive issues like gender-based violence that we are working in Nigeria with the faith community, promoting male engagement in parenting and couples decision-making. So there are many areas where faith can play a really strong role in supporting the activities and the interventions that we want to deliver and support at the country level. Next slide, please. But yet we find that even though the faith-based communities and the faith-based service delivery settings play such an important role in the health service delivery, many faith-based organizations do not have a seat at the table. They are not prioritized for drug or commodity supplies. Many times they're left out of critical policy processes, planning, and decision-making. And this is something that we feel needs to be addressed. The country technical working groups that decide on guidelines, on policies, on program decisions must include representation from diverse stakeholders, which include faith, private, civil society organizations, non-government organizations, and are led by the government. This is to ensure programming reflects community priorities and challenges. And I'm a firm believer that what gets measured happens. So if we put that as an indicator, if we measure faith engagement, then we know that it will happen. And Momentum Country and Global Leadership, the project that we work on, and the Global Financing Facility have included indicators to measure diversity of working group membership. And we also must create a dialogue with the government and other partners and share data to build and strengthen the relationship. Next slide, please. So how do we build a successful maternal, newborn, and child health partnership? Next slide. I think Peter made very clear reference to some of these things that I have listed here. This comes as a result of working on many global programs with multiple partners over the years. I've served in this role for almost 20 years now. And we tried to think through, like, what is it that brings a successful collaborative partnership? And there are 4 areas that I've highlighted here. These are clear goals, trust, clear roles, and commitment. And clear goals refers to partners' collective and explicit agreement on shared objectives, often by creation of formal partnerships, agreements, or unified strategic and operating plans. If you have clear roles that emphasize the place of each individual partner in relationship to the whole, it creates a shared vision of success. The most successful partnerships articulate the strategic intent behind each partner's participation and the alliance, and consider the unique competencies that each partner brings. As I mentioned in the beginning, that we have so many technical areas and cross-cutting areas. If we didn't have unique partners providing those unique competencies, we would not be able to deliver a successful integrated program. I think trust is a really important component of building a successful partnership. Trust and mutual interdependence rarely exist at the outset of a partnership when you start, but instead they must be built over time through a really high quality communication amongst partners At a minimum, a partnership should develop a set of communication norms that encourages widespread sharing and dissemination of accomplishments, obstacles and next steps, and special acknowledgement of individual partner contributions. So in whatever we do, we need to make sure that our partners are recognized for the special skill set and what they're bringing. And then the fourth component is the commitment. It's generally presumed when partners elect to join a partnership, but there's no guarantee that it would continue, and it needs to be sustained and built up over time. And partners inevitably differ in their allocation of time and resources and influence. And recognizing these differences and continually reaffirming partner interest and investment allows partners to adjust their expectations over time. Every partner also needs a well-coordinated exit strategy, a plan for dissolution and eventual transfer of responsibilities to other stakeholders, because all these, when you come together for a partnership, these projects end, and we need to make sure that there's a way that we can move forward. Now I'd like to share a few country case examples. If you could go to the next slide and the next one. So in our project, we have been really very, very lucky to have CCIH as a partner that, even though we are only 18 months old and we have operated through the pandemic, we have several examples of some great work that has been done through our faith-based partners. So the first one is looking at the coverage of immunization during this phase, and a global landscape analysis on faith engagement in immunization was done, and country case studies looking and diving deep into the opportunities and challenges for religious leaders' engagement in immunization. And some of the select results are highlighted here that highlight that we know it's important to engage faith leaders to promote immunization. We know that listening and dialoguing with faith leaders is critical to finding theologically acceptable solutions to vaccine hesitancy. And COVID-19 elevates this urgency of the work, as vaccine hesitancy is being exported from many countries in the West sometimes. Next slide, please. Another exciting piece of work that was done was looking at improving resiliency of faith-based organizations that are drug supply organizations. We supported 8 faith-based drug supply organizations across 5 countries to do a self-assessment on their supply chain and measure the areas, the capability, the functionality, and the performance, and identify the critical bottlenecks. And that was done in a very rapid manner so that these larger drug supply organizations and smaller drug supply organizations could highlight where are the major critical gaps. And now we can develop opportunities for where they need the improvements and how we can support them, or other partners can support those areas. So I think the first step in identifying the major bottlenecks was done very quickly, and now we can work with those drug supply organizations and others to see how we can support these entities. Next slide, please. Then we also, because we were launched right after we were launched, the COVID-19 pandemic was upon us. So one of the things that we worked on was looking at how we can support facilities to improve their water, sanitation, and hygiene practices. And we worked in Uganda, Ghana, Sierra Leone, and Bangladesh through faith organizations to identify facilities that could undergo an assessment of health facility and WASH IPC readiness, and then support quality improvement committees to identify their quality improvement aims and prioritizing COVID preparedness via virtual and in-person mentoring. And we have seen some really strong improvements in their scores on how they have done after the e-mentoring and hub and spoke sessions, because we could not do anything in person. So we could have only e-mentoring and through the training that we could do with these entities. But they have shown some really great improvements, and we are looking forward to seeing how quality improvement has also happened in these facilities. Next slide, please. Let's not forget, if we can go to the next slide, that the issues that we work on are maternal newborn health challenges. And if you were to look at the world from the maternal mortality perspective, you see the map of the world would look something like this, which shows where predominantly the maternal deaths are happening. And it's the one indicator that has the largest disparity between the developed and the developing countries. Next slide, please. And another indicator I wanted to point out is the lifetime risk of dying, which is based on the pregnancies that a woman has during her lifetime and the risk she faces with each pregnancy. And it's in sub-Saharan Africa, that risk is almost 100 times than compared to the US or other Western nations. Next slide, please. We also know what causes maternal deaths, and this is a map, this is a pie chart that demonstrates what are the main causes of maternal deaths, like severe bleeding, pregnancy-induced hypertension. But we also have very simple, low-cost interventions for these, and we need to make sure that these are provided to every woman when she comes in for a delivery. Next slide, please. And our value add as a global program is to bring the country perspective to the global discourse. And we have worked with global partners to develop several policies, guidelines to highlight the interventions that need to be provided and how simply they could be provided. Next slide. I also wanted to highlight that Align MNH is a new platform that has been launched that allows for one place where we can find all the information that might be useful for our stakeholders to share experiences and evidence to support countries in realizing their maternal newborn health goals. And we want more and more people, the communities of practice and technical working groups, to join this Align MNH so we can have a shared approach to how we address maternal newborn health in countries. You can also join technical communities of practice, technical working groups, to hear the latest evidence, and all of the ones that our program is involved with are listed here. You can become members of this and hear the latest. So if you have any questions or if you have any ideas that you want to share, that can be part of these communities of practice and technical working groups. We also hope to have some deep dive in countries through the work with Align MNH and our project to really understand how technical working groups can support their membership and also support their maternal newborn health goals. Next slide. I think I'd just like to summarize after the impact of COVID. So we know that there's, during COVID, there was a demand reduction. Women and families were fearful of going to health facilities. Healthcare providers were not equipped. There was workforce reductions where healthcare workers got sick, and there was severe disruption in supply chain. And we have to keep recognizing that more maternal deaths can happen as a result of not providing family planning, essential services, antenatal care, and childbirth and postnatal care. We have to make sure that women and our families and communities recognize that they must come, and our services should be prepared to receive them and provide them with high quality care. Next slide. I'm not going to go through this as my time is running out, but many countries developed and adapted guidance on what to do during COVID, how to monitor disruptions, how to provide an improved package, how to make more services available through outreach. So we can recognize that there's many countries have done many things to overcome the disruption in essential services that happened during COVID. And we need to highlight and promote these services going forward. Next slide, please. So in summary, I just want to say that expanding and enabling partnership among health and non-health actors, including public, private, and faith sectors, is absolutely critical to reach sustainable development goals and national country targets. The faith communities, as I've demonstrated, plays a very essential role in effective MNCH partnerships and delivery of services. And we must create an enabling environment for the faith sector to work and deliver services within countries and communities. So I'd leave you with this. Thank you so much.
Thank you very much, Koki. That was wonderful. I was busy taking some notes and looking at your slides, which are very well articulating. I'm just pleased. I was just looking at the participants. We're now 139, which is very good. And you see so many names, some that are familiar, others are not familiar. So I think we are doing very well, and we should also invite others so they join us in the next session. Now we are moving on to the next section where we are going to watch a short video. The theme is, what does governance look like at a community level? We are fortunate to hear today from community members affiliated with health facilities in the Christian Health Association of Liberia and Christian Health Association of Sierra Leone. Let's hear from these community members.
I'm Michael Mbama, member of the Community Board members in Locust Village. The reason why we have gone to this level now of this clinic, it is because of the sort approach we got from CHA. CHA came with this sort approach, and this sort approach we look at it as really a very good something because it helps you to build your action plan. And based on our action plan, we choose that we build a community clinic here. We also, in that action plan, we talk about water and sanitation. So right now, even in the community, we have more than 8 hand pumps here. So, and the clinic was one of the things that we really focus on that we should build. And this sort of approach, it can help you. You NGOs can just come and start making decisions. It is you people. They stimulate us. They come with those approach. They stimulate us. We ourselves are the one that will take the initiative and say, look, this is what we're supposed to be doing for our community. And on the board meeting, we always have meeting here. We call all the surrounding villages here. They are part of that board, community board. We call them every month. We have a meeting here so that we can know what are some of the lapses and what are some of the improvements. And they will always tell us, even here to give services, we ourselves as community, together with the clinic, we all sat down, we said, this is what we can be able to afford for the services. So it is the contribution of every member of this board that we are now reaching this far. So we don't, the clinic does not take unilateral decision. They work along with us.
How long have you been part of this board?
I've been part of this board almost 1 year and some months now.
So
Because the clinic was open on the 24th, 20 September 2019.
And what do you think is your most important role?
Our role here is to see to it that our people receive the maximum services that the community is supposed to receive. And the services that are supposed to be coming in here, like where we talk about vaccine, where we talk about TB, those facilities that we warrant the people to come here so that they can be going distances. So it is those things that we are working out, and we are saying we are always communicating with the community, and the clinic is now working on all those things. So today we are happy that the clinic is now booming.
I am Reverend John Kaziimba, the National Superintendent of the Westland Church of Sierra Leone. The Westland Church of Sierra Leone emanated from the American Westland Mission, established in 1889, with 3 basic arms: education, the church, and health facilities. The health facilities is coordinated by a director of the healthcare ministries, which I oversee. The healthcare ministries has 3 community health centers in 3 different districts and 1 referral hospital in another district, which was established in 1959. This hospital covers 180 to 200 catchment populations. It has 120 bed capacity. It supports the government with free healthcare ministries or services by helping the under 5, pregnant women, and lactating mothers. It is about 65 miles away from all other referral hospitals. The relationship with Church Rule has been very good for this long, and we are very much cooperative with the Church Rule Secretariat in that we always meet at conferences, regular meetings, consultative meetings, seminars, to ensure that the policies are effectively and efficiently operated by the secretariats. We don't just meet and discuss policies, but we also encourage our staff to comply with the policies of the secretariat so as to enable them achieve their maximum goal. Secretariat has been very, very supportive to the staff by providing in-service training, especially in the area of the IPC, to ensure that there is hygiene, proper hygiene, and other health required in the health facilities. Church is very much good and very useful in the nation, not only for the provision of infrastructure, provision of some other facilities like lights and some mobilities which they are having from donors, but they are also working with the government so as to ensure good relationship between the facilities and the government itself. Very recently, they have established an MOU on behalf of the facilities in ensuring quality or qualified workers, such as nurses, technicians, and doctors in the facilities. We want to say thanks and appreciation to donors, international donors and agencies which have been supporting Churchwood to enable them accomplish all that they have done. We are looking forward to seeing donors, the churches, and Churchwood work together as a team so as to achieve the Sustainable Development Goal 3, which is ensuring healthy lives and promoting well-being for all at all ages. Thank you very much. We are looking forward to work in a very much cordial way. God bless you.
Thank you very much. That was our colleagues' experiences from Liberia and Sierra Leone, also at slightly two different levels. At the national level as Christian Health Association of Sierra Leone, but also the other perspective from the community served by facilities that are members of the Christian Health Association of Liberia, to show actually how governance looks like, or good governance that we can share about, where the local communities are involved in decision-making for their own health services and health care. We are moving on. Now our next part, we are going to hear from Dr. Rick Gardner of Kiwa International. Rick is going to talk about a shared governance model when spiritual health is equal to health and administration. Dr. Rick Gardner serves as Chief Medical Officer for Kiwa International and the Medical Director at Kiwa Ethiopia. As a Chief Medical Officer, he engages regularly with the medical directors of each Kiwa hospital, and he's an active participant of the Kiwa executive leadership team. He completed his surgical training in the UK and spent his fellowship at the Hospital for Sick Children in Toronto, Canada. He has served as Kiwa Ethiopia. He has served at Kiwa Ethiopia since September 2013, both as a consultant orthopedic surgeon and as a medical director. Rick, you have about 10 minutes. Over to you. I think you are still muted.
No, I think I've just been unmuted. Thank you.
Yes, thank you.
No, thank you very much. I'll just share my screen if I'm allowed to. If I can, I think Kathy's on there. She's going to let me share my screen. But whilst I'm doing that, it's really just like to say just what a great honor it is for me to join this wonderful conference, for the incredible wisdom that we've heard so far. It's a real honor for me, and thank you very much for your time. I hope this is projecting on your screens. Cure's foundational mission is rooted in Luke 9:2, and he sent them out to proclaim the kingdom of God and to heal the sick. Now, centered on this, we strive to provide world-class surgical care to some of the most vulnerable children for the proclamation and the demonstration of the gospel. And it's not something that we can split into two separate tasks. As Christians, we believe that medical healing and spiritual ministry are two sides of the same coin. And we see that our patients as divine appointments. Every child and family member who comes to a Cure hospital is a God-given opportunity for them to hear the gospel and for us to share our faith through service and compassion. Now, we have hospitals in 8 countries. The first was in Kenya 25 years ago, and our newest hospital is in Zimbabwe. Now, we care for children with treatable disabilities, providing orthopedic surgical intervention, neurosurgical intervention, and plastic surgical intervention, performing around 12,000 or so surgical procedures each year. Now, the United Nations has a bold agenda called the 2030 Agenda for Sustainable Development, where 192 UN member states pledged to ensure that no one would be left behind. Now, we care for children who would otherwise be left behind as adults. But being left behind is so much more than about physical disability. You could visit any one of our hospitals and talk to the children who are currently inpatients in those hospitals. And you would hear common stories of children refusing to play with them, teasing, insults, and even if the condition does not prevent them from walking, many will stop going to school. And they grow up feeling neglected and isolated and forced to believe that they're worthless. And their families also share this burden and become bitter. In time, maybe considering their child as a burden. Now, these two slides of Woobulum on the left and Hyatt on the right are such examples. Woobulum sustained a severe burn to her foot as an infant, and the resultant scarring dragged her foot outwards, causing her to walk on the inside of her ankle. Hyatt, a severe skin condition, due to community stigma, was kept indoors, resulting in such severe rickets that she could barely walk. Now, for Woobulum, with gradual correction of the deformity and then later skin grafting, Woobulum was able to walk normally and without pain. Her healing has been far deeper and far more significant than even the external physical change. Now, Hyatt was treated for her rickets, and then she needed surgery on both of her hips. And she now walks to school, and like Woobulum, has a new confidence in herself and her future. Now, all of the medical treatments in our hospitals is undertaken hand in hand with our ministry team. Now, each day they spend time with the child and the family, understanding the challenges and the trauma they've been through. And they tell the children and their families about Jesus. Now, change happens from within, and alongside the physical change they see, hope shines through, and the parents who bring their child to our hospitals do so out of hope. Now, Fatuma and Miriam's mother brought them to our hospital in Ethiopia, hoping for a better future for their child. Hope that they would not be left behind, hope that the stigma that has plagued them would be lifted. Now, many do not know about Jesus and do not know that it is following his call that our hospitals exist. We care for all children from all faiths, and we provide care for children regardless of their ability to pay, whether they need a small procedure, an overnight stay, or have to have several surgeries and stay for months. The parent will often ask why our hospital feels different. Why do we do what we do? Now, we see Christ in the faces of the many children that we have the deep privilege to care for. And it's our joy to follow the commands in Isaiah 1:17, to learn to do right, to seek justice, and to defend the oppressed. Now, on a patient's discharge, our spiritual team connects with a family with a local church, where they can continue their journey to a deepened faith. And they're there when they return to clinic with the hope and assurance of a better future. And the team reminds them that whilst we have straightened their legs, it is God who truly heals, and that is why hospitals exist, just to share the love and the hope of Christ. It really is a joy to work in a hospital where we share this mission, where we understand the privilege and responsibility given to us by these parents who hope for a better future for their child. Now, all of our fellow co-workers know that ministering to patients is not just the work of the spiritual team. No operation happens in a Kiwa hospital without prayer. We prepare our patients, we do the WHO checklist, but before an incision is made, that patient is prayed for. We pray for wisdom during the surgery, that the child will recover well, that through the surgery and the stay in the hospital, that the child and their family will develop a deep, lifelong faith that is more valuable than any physical healing. So you can see how essential our combined ministry is. It really is 100% medical, 100% spiritual. And Kiwa's structure reflects the importance of our ministry. We don't just have hospitals with healthcare professionals who straighten legs and restore the function in hands and relieve blockage from cerebral spinal fluid in children with hydrocephalus. We have an intentional spiritual ministry that is the core of all we do. And in order to keep these two aspects on equal footing, our model of leadership has been key to preserving the vision and the purpose of the organization. Now, the central Christian ministry of some organizations has drifted over years, but with our senior leadership in each of our hospitals, it's really helped to keep the balance. The leaders in our hospitals are three: the executive director, the medical director, and the spiritual director. And the spiritual director doesn't just function as a pastor, but is a core leadership role in the running of the hospital and the direction of our work. Now, he or she leads a team who connects with the patient and their family before, during, and after the hospital stay, and they will travel on our outreach clinics, where we see many children closer to their own home, and they also guide our focus to serve families and unreached people groups. And we shouldn't underestimate the anxiety that many families feel when they travel for long distances to our hospitals. Now, some will travel for days, often making their first trip to the capital city. But to have made a connection with our spiritual team at a clinic close to their own home and to be welcomed to the new hospital environment sets a foundation of trust. We believe that by keeping the spiritual service at a leadership level, it becomes clear to all that it's got an equal value to the medical need. And all of our co-workers go beyond the medical care and work closely with our medical team. And we do strive day in, day out to follow Jesus' commands in Matthew 25, that whatever you did for the least of these brothers and sisters, you did it for me. Now, since Kiwa's inception, some 1.2 million people have been reached by the gospel. But what do these numbers mean? Many children and family members leave our hospitals having heard and experienced the gospel through the care they have received. And other families who for years have carried the burden and the blame they have felt in having a child with a disability leave the hospital with a new or restored faith in Christ. All leave our hospitals with a new hope for what the future holds, to know they need not be left behind as adults. Now, I've been asked whether such a model is achievable in the government system. And I believe it is, but I do not underestimate the challenges. There are so many vulnerable patients, those who are physically disabled, young adults who have gone through various forms of abuse who are in great need. And in these cases, a combined focus on the spiritual as well as physical health is essential to bring full healing to these patients. Now, just caring for the immediate physical need is not total care. I mean, C.S. Lewis famously said, "You don't have a soul, you are a soul, and you have a body." We all have a great spiritual need, and perhaps it's never more apparent than when we're in hospital and no longer feel in control due to sickness or injury. Now, some hospitals do have a chaplain, but they're typically not involved in policy formation, and they do not serve on the hospital leadership team. And it's therefore hard to put a true integrated care into action. So for those of us who are attending today, representing hospitals that are open to dual mission to provide physical and spiritual care, it does come down to leadership. The hospital has to have a vision for the holistic care of patients. And it's this vision that needs to be communicated and mainstreamed throughout the hospital. In some situations where it's not practical, given that many governments are secular, and there's usually a separation of state and church, and what then? Can we think outside the traditional models of where we see spiritual ministry being most effective? For example, where in the different touch points of patient care are there opportunities for spiritual ministry? Are there any of these outside the hospital but are still linked with the patient care? And for this to be commonplace, a paradigm shift would need to take place to help the hospital leadership appreciate the need for a spiritual focus in their institutions, making patient care truly holistic. And while we're still a long way from this, we know how important it is. We live the daily evidence that many patients have a deep spiritual need that should be addressed. Thank you very much for your time. I really appreciate it.
Thank you very much, Rick. One of the disadvantages of moderating a session is that you lose out some of the good points as you're looking at the time, but with one eye I was following up, and I a little bit interacted with the Kiwa hospital in Malawi. As a beneficiary of services, one of my family members actually received several surgeries from a contracture on the foot at Kiwa for some years ago. And then I also interacted and worked with them a little bit when I was heading the Christian Health Association of Malawi. And I've seen Ronald, my friend from Uganda, saying he lives next to the Kiwa hospital, but didn't have much insight into what they are doing. So I think that's a point that we need a little more deliberate efforts to cultivate these linkages at the local level. And I like the theme of our conference this year, because it starts with an active verb, cultivating unity in global health. So unity will not somehow come by itself. It has to be deliberate. It has to be cultivated. Thank you very much, Rick, for such an insightful presentation and sharing those experiences. Now we are inching towards the end of our session now for this part, and then we have a few questions which we have received. And I will ask all our presenters to get ready and get near the unmute button. We'll start with Dr. Agnes. You mentioned a few areas, but Jean Sack is asking for some specific examples, if you may, about the successful collaboration, especially in response to the pandemic. Dr. Agnes. Okay, we will, she may be joining us, but Peter, you are there. A question from Patricia Kamara from Liberia. What strategies did you use to strengthen your relationship of health? Peter?
Yes, many times more, a very legitimate question. It borders on the key issue of relationship with government, which is always an evolving phenomenon requiring daily investment. And the pathway to strengthening partnership with government are two ways. One, hardware and software. Let me start with the software. To strengthen partnership with government, you always have to be legitimate, visible, and reliable in terms of projecting Christian identity, service ethos, and core values at all levels of the partnership. Always trying to promote human-centered considerations, compassionate service provision, and representing the poor and needy by having safety nets. And then also volunteering to be at the policy table through membership of several committees. For instance, during the COVID, CHAG was part of all the committees, and because of that, we had 20% of all the government PPEs allocated to the health sector. Very important. So maintaining that dignified and physical presence at all times is also very necessary. And then finally, within the software, showing evidence of CHA's attribution and contribution to national health outcomes. So this software, very important, but it must be crowned and consummated by hardware, which is one, there must be an MOU and administrative instructions that specifies the rights, responsibilities, and the roles of each party. And that MOU is very important because you have fluid government changes, technocrats and bureaucrats also change. So an MOU is very important. For instance, Chad, after many years, had to sign an MOU with government in 2006, accompanied by administrative instructions. And this MOU, shows how Chad will have to collaborate with the Ministry of Health in terms of service delivery, its share of human resources, information sharing, and resource allocation. So in short, the pathway of strengthening CHA government relationship is through hardware of formal partnership and the software of being legitimate, being present at the policy table and demonstrating reliability in the provision of quality, affordable services. And it is very important at a time when we are looking at health system resilience, recovery and response in COVID times. Partnership with government is indispensable and is a pathway for maintaining sustainable growth and development of local CHs. I think that this intervention will be helpful in strengthening the relationship and partnership between CHs and that of government. Thank you.
Thank you very much. Hardware and software. I would also like to add, maybe also from my experience at the national level, is that, you see, we started our session with the Archbishop, who is the spiritual head overseeing a large portfolio. And I think that engagement at that level is also important. Whereas the head of the Christian Health Association at the national level can be seen as a counterpart of the Secretary of Health at the country level. Then above the Secretary for Health is the Minister of Health. And so there also has to be readiness on the board of the Health Association, the board to link up at the ministerial level, that level of engagement. And then the church leaders must also be hands-on. So that type of political engagement is very important, so that the Christian Health Association or those that are working in the health sector are not alone, but they are seen to be direct arms of the church. So the church leadership must also be part of the team, cultivating and safeguarding that relationship, because it has to be cultivated. It also has to be protected and managed. Dr. Koki, you answered a few questions already, but we are here and you are there. Let's give you an opportunity also just to highlight a few other areas. So the question was about providing health education and versus family planning to adolescents.
Yes, I think it was a great question, and it is definitely a challenging area to work on, but I believe that we can ensure that adolescents have access to health knowledge and support where they can seek services if they need to. And those services need to be provided in a non-discriminatory way. I think in the past, there have been services that have been set aside with youth focus or adolescent focus. And sometimes youth and adolescents do not want to use those services because they feel that they're being identified as going into those services. So we just need to make sure that providers are understanding and we have a responsive health system, which includes provider training, but goes beyond that to include supervision and expanding access to private sector outreaches and other sectors that can provide services. I think we also need to focus on having a supportive family and community environment and supportive laws and policies for young adults to have access to information firstly, and then services as needed. And many times our project is working specifically on this area. And we are also going to be working on, in some countries, whether it's through peer educators, in some countries it may be through school-based education, but we need to find out how best to reach young adults so that they are able to understand what's happening to them and how they can make decisions about their reproductive life.
Thank you. Thank you very much. I will just make a small addition for us as Christians when you talk about community engagement. The community is not monolithic. And even if you live in geographical area X, you belong to many communities at the same time. You may have your school community, you may have a community based on your age group, you may be a community, belong to another community because of your work, your business, or you may have a community based on your church or religious grouping. And I think many times we forget that. So I think that's a very obvious entry point for Christian health workers, that the church and the church community is actually one big entry point. So programs like that, when they have specific and deliberate strategies of engaging with faith communities to begin with. And once you engage with faith communities, Christian communities, it opens up opportunity to engage with faith communities from at an interfaith level, Muslims and Jews and Hindus, depending on the different geographic areas we're in. So I just want to encourage us that we should not, when it comes to programming, we should not forget this obvious community, going there with our programs and letting them know this is what we are doing, this is how you can be involved, eye screening, family planning and all that. Dr. Agnes, thank you. You have, there was a question for you. The question was really asking you to give a few examples about successful collaboration in this time of pandemic. Do you have any specific examples you can give to that?
Yeah, good afternoon. Yes, definitely. It's not possible to go it alone. And during the pandemic, we've had a few successful collaborations from partners, which were, some of them have been long-term partners, others were new partners. To be specific, in Malawi, for PIH, we started preparing or being ready for the pandemic as early as January, which was a bit earlier than the nation. So one of our long-term partners is the UN family. Our hospital is a preferred, I would put it a preferred or UN designated hospital for their staff members. So looking at the pandemic, the COVID-19 specifically, we had requested them to help us with our response efforts. We wanted to put up a tent where we could stabilize and at least be an early responder to the COVID-19 patients. And they did, indeed, through WFP, we got, UN helped us with a tent, which they installed. It was able, it was initially supposed to be a 32 bed capacity, but we made it 20 just to give it enough room. We also had successful collaboration with missionary groups. Most of you know it, SIM, Service in Missions. They provided us with resources. Number one, for PPE. Number two, the resources we used to buy some equipment. And more importantly, some of those resources, we used them to educate or advocate preventive messages in our community, targeting specifically religious leaders. They also supported us with mental health services to support our workers, especially the frontliners who were at the very front line managing COVID, and that program is still ongoing as I'm speaking. The other group of our partners is UCLA, University of Carolina, Los Angeles. They also supported us both in technical capacity as in clinical case management, but also sent us some PPEs, resources to get PPEs and stuff. So there are a lot of, even the USAID grant aided, we were able to via some funds to support the sites where we are implementing the USAID grant aided programs. So all these partners I've mentioned before, but there are many more, including just new partners who were just well-wishers. They would come out and support us. Recently, we've had support from WHO. Their team of experts, consultants came to train our staff on case management, which has been very, very helpful. Yeah. So many. Yes. Thank you.
Thank you. We are remaining with 10 minutes, which is not very short time. We still have a bit of time to give your thoughts. And I'll go to Rick now. And while Rick is answering that, I will ask you to also have your thoughts, especially Peter and Agnes, have your thoughts on this issue. Dan is asking, to show legitimacy of FBOs to governments and multilateral partners, what's the most important evidence to demonstrate, and how is this best shown? Evidence of outcomes or functional partnerships or spiritual element? What is it that will give you a seat at the table? I think sometimes we need to build our case. We need to package our case in a way that the others can understand. So what is it that is going to unlock some of these opportunities? So Peter, you get ready. And then I will also ask Koki to have also some closing thoughts on working with partnerships with governments. But now Rick, but as Rick is answering, there's a request for your contacts in case some of the participants would like to give a follow-up question or to network in other ways. So I would like to ask our panelists to write your contacts in the chat, and then the participants are going to copy that, to take note. But now, Rick, the floor is yours.
Yeah, no, thank you. Speaking specifically for our organization, we strive all the way through to become an integral part of the healthcare of the countries where we serve. And I think, what does that really look like? We don't shelter behind our four walls and just receive, the children coming through. We're very intentional about serving alongside our brothers and sisters who work in the government hospitals. And that might be that sometimes we'll join them in surgeries in the government hospitals, sometimes they'll join us. But probably one of the most intentional things we do is through training. And so we have residency programs in the countries where we serve, children's orthopedic fellowship programs, children's neurosurgical programs. We have a waiting list where I recently left Ethiopia to start working on a new hospital in Zimbabwe, but I spent 7 years in Ethiopia, and the waiting list there is several thousand children strong. Really just a sign of just the huge need in a country of 110 million people. But we have residents, orthopedic residents coming from all corners of the country to learn how to take care of children, and people who are fully qualified as consultant orthopedic surgeons to spend a year with us to learn the specifics of children's orthopedic surgery and to go back to their government hospitals to train others to do the same. And so a big focus for us within the government is to be able to train others to do the same and to be a catalyst for change within the countries where we serve. We have many volunteers who come through, and we encourage them to spend time in the government sector as well. And I think by being really good partners within the cities where we serve and trying to build up national capacity, that it's been a wonderful combined relationship where we have become integral to the healthcare service in the countries where we do have hospitals. I'm now here in Bulawayo in Zimbabwe, and we opened this new hospital 3 weeks ago. The official opening is happening tomorrow with the President of Zimbabwe coming to us. But from the outset, training is going to be an important part of what we're trying to do here to really help develop national capacity. And we found that that is something which has been very well received. It's a huge joy for us. And the shared ministry that we have, whereby we have such an intentional ministry with our teams who are with the children every step of the way. When government trainees will come along and work in our hospitals, they do see something different, they do bring it back. So I think for us, being a good partner is through quality provision of care for the children who we have the privilege of taking care of, and training others to do the same.
Thank you. Training is, I would like to, if you agree with me, what Rick you're saying is, make yourself useful. Okay, fill a gap, see where the gap is, fill that gap. Don't put yourself in a corner. Don't segregate yourself. Oh, we are church, so we sit in our little corner here. Oh, we don't have money. Oh, we are waiting for our external partners. With what you have, make yourself useful. And Peter, you said you attend a meeting, volunteer to take notes. Come up with the first draft. Don't say, I'm not from the ministry, therefore I'm not going to be in this drafting team. Volunteer, make yourself useful, and see where the gap is. What do you add, Peter? What sort of data, what sort of information do you think is critical to open up relationships, partnerships with government? Peter, unmute yourself.
Yeah, many thanks. Very important. How do we demonstrate functional partnership with government? Very legitimate. Oftentimes, Christian institutions are so emotive, spiritual, and intangible with the great work that they are doing. And therefore, the world sometimes fails to recognize the exceptional contribution they are making in the health sector. I think one of the ways and means of doing so is to document our contributions, document our great work, demonstrate that in fact we are living our mission of promoting Jesus Christ healing ministry, which is to say to ensure access to equitable, high quality services, especially to the marginalized and the neglected segment of society. We should demonstrate how we complement government by showing that we are filling gaps and overlaps that government probably is unable to do because of its structure. And also, most importantly, the need for stewardship and accountability is always the missing link in the health sector. How do we take resources, utilize the resources, and account for it to government and partners in such a way that we become reliable, we become legitimate, we become the champion and advocates, and become the conscience of the entire health sector. It's about the use of evidence for the great work that we are doing. So the interface of spirituality and physicality is very important. It is time for us to be assertive, active, rather than being passive in the way we demonstrate our presence in the health sector. We are doing so much, we are using little for more. It is time to be visible, it's time to be accessible and show to the whole world that we are indeed the light of the world. After all, Jesus Christ says, how do you become important if you light a candle and put it under the bed? It is time to be that visible. And that will make us more respectable, dignified, and acceptable within the entire health sector. Thank you, Yeboah.
Thank you very much, Peter. Now I will give you over to you, Koki, to add a few sentiments on global partnership or government partnerships.
Yes, I think Peter covered it really nicely, and so did Rick. I just wanted to add, I think our motto from our CEO at JPIGO is when nurses or midwives don't have a voice, she's always used this saying that if you don't have a seat at the table, bring your own chair. And like Mwai was saying, like if you don't have a voice or an ability to interact or partner with the government, we need to make sure that that happens, and it takes an effort from ourselves. It's not just going to happen because the government is going to open doors for us. So I think we just need to make sure that we push for that. And as Mwai was suggesting, you could volunteer in different ways to have a seat at the table. I think two other points. One of the issues that we struggle with in reporting with the government is data that is shared with the government in terms of regular health information systems. And within the private sector and sometimes maybe the faith-based sector, I think that there's a recognition that the data is not shared so that the government can report on everything that is happening in terms of service provision. So I would say make sure that we are sharing the data that we are recording in our own services. And then the other aspect would be that we make sure that when we are negotiating where we provide services, there are many times where government cannot provide services adequately. And I think they would be most appreciative if the faith-based sector can then opt to provide services, because we know that the faith sector works in very adverse and very challenging circumstances. And sometimes that partnership can really lend itself to being very fruitful because you are providing services in areas where the government is unable to do so. So I think those are two aspects I just wanted to highlight. Thanks.
Thank you very much. We are coming really towards the end of our session, and our panelists, you have been wonderful. Actually, what I'll do is I'll rewatch this so that I can now just sit and listen properly. And in this remaining 1 minute, I really cannot do any justice to summarize what you have, the great wisdom and insights you have shared with us. But seeing you, Koki, talking, sharing with us, the four of us are working with church organizations. You are not working with the church organization. And as you are talking, there's really, if anybody just tunes in, may not see any difference between your language and your passion and how we are making this presentation as a team. What am I saying? I think as faith-based organizations, sometimes we marginalize ourselves. Oh, they cannot work. Oh, they will not listen to us. Oh, they cannot, you know. Let's be open, because even non-faith partners are also willing, may actually be very formidable partners to support and work with us. And you see in the introduction, I removed the word secular, because sometimes we say secular organizations like they don't have values, they don't have, you know, commitments, they don't, no. Some of these non-faith partners have very strong values. So in terms of unity and in diversity, as faith-based organizations, one of the key issues is in building partnerships. It's not only, let's look beyond our little corner. Let's not box ourselves, let's not prejudice ourselves. We may find actually very helpful partners from unlikely angles. Finally, just to close, one of the areas that I find very motivating is the story of Daniel, that they were trying to look for a fault in him, you know, he's going to find, and they said they have watchdogs, you know, they had spies and what, they said they couldn't find any fault in him. Why? Two things. He was not corrupt. Secondly, he was prudent. He was not negligent of his duties. And being negligent of duties is when you are a leader and yet you are not doing the leading. You're being negligent. You are a leader and all you're doing, you are managing. You are a leader and yet the ship is not moving forward. You know, you found the organization at point A, you are not corrupt, but you are negligent of the leading. You are not doing the leading, you know, the thing is not moving forward. You found it at point A, you take it for 5 years, you leave it at point A. That's being negligent. What have you done? I didn't steal any penny. I didn't, yes, you didn't do. But the main thing you were employed, you were hired is to lead, to take this country forward, you know, to take this organization forward. Because as time is moving, if you're not moving, it means you're going backwards. But this guy, he was not negligent of his leadership obligations, to vision, to think, to build new partnerships, to cultivate relationships and to develop. And I think all of you have been able to capture this, to think beyond, where is the gap? And as Kiwa, you see there's the gap, you come in. As a PIH, where is the gap? You saw a very critical gap in providing high quality tertiary level even education in the capital city. And you came in and did that. I think that's a very high element of leadership. Thank you very much to my esteemed panelists. Now we are coming to the next part of our section, of our session today. But for now, thank you very much. And as the moderator of this session, I'm glad. I now hand over back to Mona. Thank you.
Thank you.